Okay, hello everyone. Today we are honored to have with us Tennyson Lee, a member of the British Psychoanalytic Society and a consultant in general adult psychiatry and medical psychotherapy, the lead clinician at Dean Cross Personality Disorder Service of the East London NHS Foundation Trust, and a certified teacher supervisor in TFP, accredited by International Society of Transference-Focused Psychotherapy, of which he is a board member. He is a founding member and chair of the TFP UK group. He is lead of a TFP training project which has held courses in China, South Africa, Italy, UK, India, and Malaysia, amongst others. He is the co-director of the Center for Understanding of Personality Disorder, a research and training unit linked to Oxford University and Queen Mary University, and he teaches on personality disorder internationally and has spoken on narcissism on BBC Radio 4. TFP was developed by Professor Otto Kernberg, a renowned psychoanalyst, psychiatrist, and researcher, and it is considered one of the most sophisticated and empirically supported psychodynamic treatments available for complex personality pathology. The goal of today's session is to begin to familiarize with transference-focused psychotherapy model, its theoretical basis, clinical methodology, and how it can be robustly integrated into our daily practice. Without further ado, Dr. Lee, we're truly honored to have you here. And to begin, could you please introduce yourself and share what inspired your dedication to transfer-focused psychotherapy and its applications in clinical settings, perhaps?
So first of all, thanks very much, Adriana, for the invitation. I'm honored to meet with you and to think with you and your organization about TFP. So I'm really looking forward to our chat. So in terms of sorry, what's your first question? My background?
So we would like to hear perhaps a little bit of what drew you to
Yes,
transfer-focused
yes,
psychotherapy and
yes.
its application in clinical settings.
So my training is as a psychiatrist, and as a psychiatrist, I'm very interested in what makes us as human beings tick. And so therefore I became interested in personality and personality disorder. And due to that interest, I've worked in personality disorder services in all of my psychiatric work. And due to that interest, I've done trainings in various therapies, including mentalization-based treatment, psychoanalysis, and transference-focused psychotherapy. And also part of my background is in public health. I initially trained in public health. So the way that it all comes together for me is that I think that given the great contribution that psychodynamic thinking can make to our work with our patients, that I think transference-focused psychotherapy is a way to make analytic thinking more accessible to us as busy practitioners. So that's why I'm particularly interested in TFP as a modality and in the teaching of TFP, because I think it has a great, it really helps us as clinicians. And it comes back to personality. When we're working with patients who have personalities, and particularly those with personality disorder, being able to think about what's happening in the dynamic with the patient is really, really helpful. And TFP, because it's analytically grounded, is very helpful for any clinician, whatever your background is. If one has some skills in thinking about what's happening in the relationship, then that's very, very helpful. So that's really what's drawn me to TFP.
That's wonderful, yes. So let us perhaps begin with the exploration of what is transference-focused psychotherapy, maybe a little introduction also about what is transference for those who may be less familiar with this particular language, and what kind of patients is best suited for.
Sure. So I'll use the acronym now for transference-focused psychotherapy. I'll say TFP just to shorten it.
Mm-hmm.
So the way to think about transference-focused psychotherapy is that it's a structural and a structured approach to working with our patients. And what I mean by structured is that it thinks about how do we understand personality, and TFP takes an object relations approach. In other words, it thinks about, and the word object relations sounds a bit sort of confusing. So I want to make it very. It's not a difficult concept. It's really just is how the individual, how we feel about ourselves. In other words, how we have a mental image of ourselves and how we have a mental image of others. So that's the structure that TFP is particularly interested in, object relations, and all that it means is a way to think what the any individual thinks about themselves or others. So that's one aspect of the structure. The other structure, and I think that it's a very interesting, I think this again is the contribution of TFP for all of our thinking as clinicians. I'm very aware that there are so many different excellent models. And what I want to do now is just to say TFP can help with the other models in this way, and that is it is very interested in the different components of personality. So, for example, it thinks about identity. It thinks about what kinds of defense mechanisms does the individual use. It thinks about how aggressive may they be. What's their sense of morality? Can you see? It's almost as though if one was a novelist and one wrote about someone, those are probably the aspects that really draw one to what makes this person tick. So that's what TFP does. So what I've said, just to go back, I've said TFP is a structural way to think about personality. And so therefore I've given examples as in particular structures as in self and other representation, the object relations, and structures as in aspects of personality like identity, level of morality, how aggressive the individual is. But I also say that it's a structured way to approach personality. And what I mean by that, and again, I think this is the contribution of TFP, that when we think of clinical work in TFP, we have a very structured way to approach it. And I think it's so useful for us as clinicians because our patients at times can be very confusing, particularly patients that are severely personality disordered. And by having, TFP having a structured approach, which I think all the evidence-based approaches do, but I think that's what it contributes. So the structured approach in transference-focused psychotherapy is we think of strategy, we think of tactics and technique. And while I don't have time to go into all the different components of it, I think what I mainly want to get across is that by having a structured approach, it really helps us as clinicians just to lean onto the structure when we really are confused about the interaction with the patient. So that's, in a way, I've tried to define the aspects of TFP, to also say that it was developed by Kernberg, I think in around the 60s, Otto Kernberg. Otto Kernberg was working in the United States with patients with severe personality disorder. And he, by that time, was already trained. He is a psychiatrist and was already trained as a psychoanalyst. But the normal approach, classical psychoanalysis, wasn't working with these patients. So what Professor Kernberg did, which I think was, there's some brilliance in this, he said, while I'm committed to an analytic approach, what modifications do I need to do, which is still psychoanalysis, but which is appropriate for the patient group? I think that's for all of us as clinicians to have that flexibility to think, what adaptations do I need to make while I'm staying adherent to a particular treatment model? I think that really was commendable. So that's what he did. So a way that we can think about TFP is it's a modified psychoanalytic approach which was developed to work with severe personality disorder. But I want to say something now about, so also to say that it's now evidence-based. So there've been a number of trials which have shown the effectiveness, and it's been adapted for different settings. But one thing I want to add on now is, and again, it might be of interest for the participants who come to Elephant, and that is, it's now been adapted for use in not just more severe personality disorder, but also for neurotic personality organization. So that's why it's there's something about its application, because it's drawn from psychoanalysis, that can be used as a modality for all the different levels of personality organization.
It is wonderful to hear, actually, specifically also this adaptation to the more neurotic personality organization. So let's see. For example, how would you describe the core clinical aims of TFP in contrast to other models like, I don't know, DBT or schema therapy or CBT even?
Yeah. So I think that the aim in TFP is, I think it sets a more ambitious aim, because it's actually working, it's actually trying, and you can see the difficulty in this. So I really want to acknowledge that it's not a magical treatment, and that at times the work is very, very difficult, but it is aiming for change in personality structure, and therefore it is aiming for it's aiming at a more ambitious level. And as I say, sometimes it fails. That's why I really want to respect all of the different modalities, and just to say that what TFP tries to do is it tries to help the patient to make practical changes in Freud's main domains of love, work, and play. It actually does try to help the patient to make changes not just at a symptomatic level, but at a fundamental level. And you can see that's very, very difficult work. And, not as though TFP always succeeds in that, but that's really the aim.
So you mentioned that sometimes it fails. What would that be a case? Do you have any example of a situation that when this would fail or wouldn't be effective?
Yeah. So a way to think about TFP is that we think of the work in two main phases. The first phase, and if we think of patients with, I'm sure colleagues would be very mindful of our patients with borderline personality disorder who act out a lot. In other words, they replace thought or an emotion with a behavior. And of course, our patients in treatment will do exactly what they do in their lives. They act out a lot. So a patient that remains acting out throughout the course of treatment is probably one that is getting less from the therapy. In other words, the aim in TFP is, and it's something that I hope that we will get onto, it's through the setting, the clear setting of the treatment frame, that one tries to help the patient to act out less. And by acting out less, in other words, that there's less time spent on worrying about the patient's self-harm or their harmful drinking, but actually getting on to the main underlying problems rather than the more symptomatic presentation. In other words, what's driving the self-harm or the drinking? So if, and that's why I'm saying it doesn't always work. But if we can manage to control some of the acting out, so that we can get onto deeper areas of difficulty with the patient, then the patient is more likely to be benefiting from the intervention. The other aspect that I think we as clinicians will also be very mindful of is which are the patients who are the most difficult to treat. And I think we would most of us would agree it's patients with narcissism. So again, I think TFP has spent a lot of time on thinking of the approach to narcissism, and I think it's one of the more developed approach, of the evidence-based. Oh, by the way, there's no evidence base for the treatment of narcissism. I don't want to make any claims that we've shown effectiveness of treatment, but in TFP we've done a lot of thinking about how one works with patients with narcissism. But in answer to your question, I think it's those patients that particularly TFP, as all different treatments, really struggle with in terms of being effective in treatment. It's such a difficult condition.
Yes, absolutely. Yes. And that's why we need more robust training, more and more. Yes. So, how is the case conceptualized and formulated in TFP? And how does that guide the treatment planning and the therapist stance?
So, maybe I can give an example just to flesh it out a bit. A patient that I always use as sort of a way to think about our borderline patients is a patient who I give the fictional name of Nina to. So Nina is a 34-year-old woman who has a way of thinking about herself where she feels she's never understood, people are not interested in her, and that actually people are out to, in some ways, exploit her. Now, she then, I suppose a shorthand way is that she often feels that she is a victim and that others bully or sort of persecute her in some way. And just to bring in the more analytic aspect, Nina's history is of having a mother who entirely neglected her. And in fact, Nina was abused sexually by the mother's then partner. And when Nina was brave enough to say to the mother this was happening, the mother completely discounted it. In other words, one can then understand from the early history she has why she feels that she's a victim, that no one's really interested in her, and that others exploit her. Now, what happened in one of the sessions with the therapist is that she's talking to the therapist about, and she's very worried about, in fact, her daughter who's just about to become a teenager, and she's worried about the daughter repeating the pattern that she had in terms of becoming sexually active at a very young age. Now, what happens is that the therapist, who's a reasonably good therapist, he happens to look at his watch because he's aware that the session is due to end. And while Nina, up till that point, has been, very absorbed in telling the therapist about their concerns, when he looks at his watch, she says, "Oh, am I boring you?" And the therapist sort of, gets a bit, and he says, No, it's just because of we reaching the end of our session. So Nina then says, with an edge, "Well, give me another 10 minutes." And the therapist says, I can't do that. So Nina says, I've just told you how worried I am about my daughter. Are you even interested in what I'm telling you? I don't think you're interested in me at all. Why carry on? You're so worried about the amount of time you have. Why don't we end the session now? We'll end the session now. By the way, I've got lots of tablets at home. I think I'll just take them all. See you. Can you see? And she starts heading towards the... Now, that's an example of what our patients might do. And I think that I suppose all the evidence-based approaches would have some way to think about it. and TFP would have a way to start thinking about that as well. So that's an example of what might happen. So I, I would think that your next question might be, well, what would TFP do about that? What might be a TFP intervention?
And also, how does the clinician manages their countertransference and interface
Absolutely,
in a way, right?
absolutely. No, I think your question now is exactly it goes to the heart of it, because we could all think, as empathizing with the clinician, that clinician feels, oh my word, have I just done the most terrible thing? Am I being in fact cruel? Have I missed something? Is she right? Can you see they would feel worried that they've done something wrong? And then they might also feel a split second later, actually, I'm feeling really annoyed now. What's going to happen in terms of if this patient overdoses? What's my manager going to? Can you see there's a whole range of emotions that the therapist has? And if the therapist can then, exactly your point, just take one step aside and say, this is what I'm feeling. I'm feeling very worried, very victimized, and very angry. Then if the therapist can think, this is not what I felt a second ago, I'm feeling it all now. Therapists might then think, this is an affect which has been projected into me. And actually, it's the experience of the patient. That's what she's feeling at present. She's been neglected because I've said it's time to end. And she's allowing me a very rich experience of what she's feeling. Now, once the therapist can start realizing that's what's happening, it just gives us just that bit of extra oxygen, a bit extra space to think and to feel less embattled by what the patient's just done. So I think your point about, going straight to the countertransference, I think is exactly what's useful about thinking in this way.
Yes, absolutely. And my goodness, how helpful that is, really.
Mm, mm,
And one of the core themes of TFP is this notion of identity diffusion.
mm,
Perhaps you could expand a little bit on what it means and how it can manifest clinically
mm.
in our sessions with our clients.
So I think that's a very important point. And in fact, what you've identified is the key concept around which Otto Kernberg developed his thinking around borderline personality disorder and borderline personality organization. And that is that the individual has very split ways in which he views the world, and it's either all positive, or with our patients, usually it's all negative. And so all of the feelings about oneself or about the other might be, if it's all negative, might be self-representation, I'm the victim, or self-representation that, I'm not, I'm ugly, or self-representation of, my feelings are bad. Can you see it's all on the one side?
Mm-hmm.
Whereas someone that's the other side of it would be, and again, this is what our borderline patients do, that they might get into a relationship where they think, their view of themselves is, I am someone who's perfectly loved by the other. This man is the most ideal man. He's a gift from heaven. Can you see that it's very, very divided? The experience is either all negative, and you can just imagine the gift from heaven might come to the next date 5 minutes late, and then he becomes the devil. Can you see how, with our borderline patients, it's very, very extreme how they move their view from negative to positive? And so that's what the example or way to think about identity diffusion. And the whole aim in TFP is to help the patient to get more of a coherent sense of their own identity. So that, for example, say, hopefully you and I have more of a coherent identity, where we might think, well, there's some aspects of myself which are not very good. I might be bit untidy. I might at times be impatient. But on the whole, I'm a decent enough person. Can you see it's having a sense of both your negative and your positive qualities so that it's more realistic? And similarly, I can say, think about my wife that, oh my word, at times I find that she can be a bit short-tempered with me. As I can think of the negative qualities, but I think, my word, what a wonderful person. She is so kind. Can you say I can think of the positive qualities? So my whole sense of her is that it's not just all this or all that, but it's a rounded view. And that, in a way, is to think that that's what we can, probably psychological health, is being in contact with reality. And reality is that we have, nice and not very nice aspects about ourselves. That just is what it is.
Absolutely, absolutely. No, thank you for that. Do therapists share diagnosis or case conceptualization in
Yeah,
this
yeah.
framework?
No,
And
that's
what
a
are the pros and cons of this
yeah,
approach?
yeah. No, that's a wonderful question. So the answer in TFP is very clear that it does share formulation. It's absolutely clear about that. Now, TFP, maybe because it was developed by Otto Kernberg, TFP is also keen on psychiatric diagnosis, and it does share psychiatric diagnoses. Now, I think that is an issue with some clinicians who might not be trained as psychiatrists. So what I'm saying is, it's just to acknowledge that that's what TFP does, but of course there are practicalities in terms of that aspect. So my answer is yes, absolutely. We would share, all of us, whether we are psychiatrists or non-medics, we would share formulation. If there's confidence about the ability to diagnose, for example, borderline personality disorder, we would share that as well. We would say, based on, and by the way, when I say this, there's a whole skill to how one discloses diagnosis. I'm not going into that aspect. I'm not saying how one does it in a tactful, kindly, gentle, stepped manner. I'm not going into that. But one would share the diagnosis of borderline personality disorder. But the reason why I think that the question you're asking is such a good one is, when it comes to the question of sharing the diagnosis of narcissism, that's
Mhm.
a whole different story.
Oh,
And that we could think probably the New York group have done the longest thinking. So this is Otto Kernberg's group in New York. They've done thinking for the longest time on TFP. And in the most recent text on TFP for narcissism, of which the first author is Diana Diamond, they don't come out on a line about whether one does or doesn't share the diagnosis. The psychiatric, they would share the formulation, but whether they, in the formulation, use the word narcissism and whether they share the psychiatric diagnosis, they say that is open to the individual situation. They don't make an overall recommendation. And I think it makes absolute sense from experience of my service. I have first-hand and at times painful experience of what might happen if the diagnosis is shared and what patients might then, how they might find it pejorative, even more so, and it's understandable, than borderline personality disorder, and how they may then want to complain about the way that they're being seen. So I think it's a very important point that you're raising, and So just to say, yes, TFP is quite strong on sharing diagnosis and formulation, but when it comes to narcissism, it says, well, it depends.
yes, okay, I understand that. And what would be the benefit of sharing? Why does TFP believe it could be beneficial to actually share the diagnosis?
Um, do you mean formulation or diagnosis?
Maybe the diagnosis,
Yeah,
which can come across as more pejorative or,
yeah,
like
yeah.
trigger quite a lot of shame or defectiveness
Yeah.
in. the patient or stigmatizing?
Um, I'm not sure that I've ever seen the rationale behind it. I think it might be partly based on just the whole ethos, and maybe based on Otto Kernberg's personality. I think Otto Kernberg um, is, I think, well, actually, let me not base it on personality even, let me base it on theory.
Mm-hmm.
That TFP, different to some of the other evidence-based approaches, is a conflict-based approach. It thinks that a way to understand pathology or the patient's difficulty is due to different drives that they have and how they manage those drives. Due to that, I think it does take a more, and when I say this, I want to be very careful. I want to say it takes a more direct approach, but by that, I don't want to give the impression that it's therefore an unkind approach, but it is more direct. And therefore, within that, I think it would be within the ethos of TFP that if they feel that there's some knowledge that the therapist has, then I think the ethos would be, I would want to share that with you. This is my view, and I want to share it. And then the TFP therapist would be very interested in if the patient says, oh, so now you're judging me, or, oh, I don't like that. Why did you say that? Then you're in the transference, and then you can think of what might be happening if the patient has become angry with you. Okay, so I'm just thinking of those aspects about the sharing of diagnosis.
One could think, for example, that for those patients that are able to have a strong enough therapeutic alliance with the clinician and they're able to take in this feedback and hold it without acting out, that it could potentially speed up the therapeutic process, because at least there is clarity about what's really going on. And then also this approach of transparency, which is quite refreshing.
Yeah, I think that's a very good point. And in a way, you see, I would discuss formulation and diagnosis more towards the end of an assessment,
Mm-hmm.
by which stage I would hope that there's some sense of moving towards an agreed way to work together. So I think that's very important. And then the other point that you're making me think is that by the time I share, or at the time when I share formulation and diagnosis, I am still assessing the patient. I'm not offering the treatment yet. In other words, it's almost like a probe interpretation. I'm saying at this point, I think I've got enough of an understanding and I would like to share it with you. Would you like to hear what I'm thinking? Patient says yes. Then I would say what I'm thinking, and then I'd say, what are your thoughts about it? Can you see that in this way, although I'm reaching the end of the assessment, I haven't signed it off? Because if the patient says, no way, you must be completely mad to think I'd even let you make that diagnosis, then I know that there's something which needs to be worked out still before we can proceed. Can you see that? I think it's
Yeah,
an important
no,
point.
absolutely. Okay, now moving on to the conceptualization of the patient psychic landscape. How would it differentiate, be different from schema therapy or internal family system, the, let's say, conceptualization of the psychic landscape of the patient?
Now, because I'm not that familiar with the other approaches, my answer might be limited by that. I think one of the ways that I would think the difference is that in TFP, the main approach is to help the patient to identify their inner world, and by the inner world, because it's a contemporary object relations approach, It's to help them to identify their main way of experiencing themselves or others, and what they then do with that way of experiencing themselves and others to make it more conscious to them. And to, I think that a bit earlier on in our conversation, you were saying to think about the transference, and in a way, I think that this links in with that question, because how the patient feels about themselves or others will come out in how they're relating to you as the therapist. And I think that the difference between TFP and other approaches might be that it thinks a bit more about how's the patient experiencing you, or how they're experiencing themselves because of their view of you. Can you see it's both things, and they're happening at the same time? And maybe the other difference, and I've just come from a workshop, a wonderful workshop last week, where in fact there were experienced therapists from all the different modalities. So mentalization-based treatment,
Oh,
schema-focused, was such an interesting conference.
mm,
So they, at that conference, it was very well organized, and the organizers presented us as the panel with vignettes, 4 vignettes. And each of us as panelists spoke to our approach. And what I thought is a difference is that in TFP, we're more willing to just identify with the patient, how they're experiencing themselves and us, and to explore it enough to try to identify whether there's a misperception. But we don't give them the answer. We try to work it out with them.
mm,
I think so. When I, was with my colleagues, for example, some of the approaches might have more been no. That actually isn't what I'm saying. In other words, they would be more prepared to state or to help the patient by saying, this is a way that I am relating to you. It's not that, please accept that I'm not relating to you in that way. It's just a very different approach, really. And that was very interesting because it made the difference in the models more clear to me. It also made me think, because when my colleagues say, for example, the schema focus or the methodologization-based treatment, when they said what they did and they gave their rationale and how they would continue working, I could see the absolute sense of it. So I think it was, maybe I'm just going on to the different approaches. I think it's saying, and I think because there might be, members who come to your training who have interest in different approaches, I think was very much that workshop last week, very much, I think, was within the spirit of respecting the different approaches, and it was evidence that basically I think that the most important aspect of working with a patient, particularly a patient with personality disorder, is to have a coherent framework. As long as we have a coherent framework and we know the overall way that we're working, that's the most important thing, I think.
yes, absolutely. That goes also for the idea of sharing a diagnosis in a very caring and empathetic way so that we can contextualize this. This is not because you're
Absolutely.
defective, but it's, you went through
Absolutely.
quite a lot growing up, and the result is that you
Absolutely.
develop this defense mechanism that constellate in this personality presentation type.
Yes. Yes.
So we talked a little bit about countertransference, but I'd like to go back a little bit there. So one thing that we mentioned is really to be aware of what's injected into the clinician. What other thoughts do you have about therapists managing intense countertransfer or projective identification in the room,
Yeah.
and thereby being able to take care of themselves, aside from obvious supervision, which is
Yeah.
obviously always vital?
Yeah. Well, maybe there's something that we should just think about ourselves. Why do we choose this profession? In other words, I think the reason why we choose it is that there's something about us which wants to heal or to help. And I think there's something then about the my sense, and I'd be interested in what you think, Adriana, but my sense is if one wants to heal or help, one is then quite prone to feeling guilty if one isn't managing that. So I think it's just realizing that we would be quite sensitive to feeling guilty, and just realizing that about ourselves and about our personalities and why we chose this profession. I think I'm more saying is that we don't feel so guilty. And it goes back to actually, colleagues, if we're working with someone with a moderate to severe personality disorder, I think what we should think is the way that the patient is has been baked in from, um, I would say, from infancy, really. It's a very long time that the patient's been doing what they do. And if we can just think that it's a very long time, in other words, what we're working with in personality is procedural memory. It's just automatic. It's just
The script.
reflexive, not reflective, but reflexive. It's just the patient, or we just do, do. And again, if one has an understanding of how memory works, to change, well, actually, one can't change procedural memory, but one can try to insert a different procedure. That takes a long time. It's very difficult work. If we just accept that, then maybe that will make us less hard and harsh on ourselves in terms of, your question about the countertransference, and we hopefully feel less guilty about that.
And this approach seems to be quite relational, so it's very implicit in its way of rescripting, shall we say, past the scripts of
Yes,
relational dyadics,
yes,
relational patterns.
absolutely,
Yeah, yeah,
absolutely, yeah.
that's absolutely true. So, okay, and so what would be a typical TFP session? How would that look like? And especially maybe with clients more with narcissistic personality.
Yeah, I was supervising a colleague this morning, actually, um, and it was such an interesting session because she's worked with this patient now for a long time, and this patient does have a problem with narcissism. Now, what this patient was saying, he was giving quite a long account of the fact that, and he's an ambitious young man, and he wants to advance in his teaching career, and he's already quite well placed for his age, but he thought he's not progressing enough. So he wrote to a senior, wanting support from the senior to progress him to the next level. And he, in the session, told the therapist, this is what the senior said to me. And what the senior said is, I feel very privileged to have been part of your training or your teaching career, and I feel very supportive. And in fact, I feel very heartened by the progress you are making. Now, the patient says it to the therapist, and there's some emotion in this, and it goes back to an earlier point that we made. So we can think in the supervision group, there's some progress. This narcissistic man can actually say something which is of importance to him, and he says it to the therapist with meaning. So can you see, we're already getting that data just
Yeah.
from the way the patient's talking about it. Then the therapist, then he wants to go on, and the therapist intervenes. Now, the reason why I'm saying this is that's an example of TFP where if the therapist thinks there's something important, different to maybe some analytic approaches, therapist doesn't let the patient just talk. They will come in at times. And I'm not saying we interrupt all the time, but in therapy, the therapist is prepared to be active. Now, what the therapist said is, what I'm thinking is that you have told me about this. In fact, your senior hasn't said that they are going to help you, but they have said that they feel very supportive of you. And that seems to be what's important about this. And the patient sort of thinks about it and says, yes, that is what's important. Then the therapist goes on to say, that's something that we have thought about you, that for you, it's very important to be thought of as being, and she said it in a way which wasn't diminished, but to be good, to be seen as the good boy, and to get approval from your from your people that you respect. And he says yes. Then she said, so there's sometimes spent, so I don't want to give a sense that she just moves too quickly. So there's some time spent, and there's some sense of him feeling understood, and there's some quietness to this. And then the therapist said, what I'm thinking now is that sometimes you feel a bit irritated with me that you have to travel for an hour to come across the city to see me. And it may be because you feel you have to be good with me, and actually at times you resent that. Now, and again, he could take that in. Now, what I'm saying is that's an example of a TFP session where the patient is saying things which are of emotional importance. It's not in the transference, but the therapist tracks it because it seems important, that in the whole sense about his career progression. But she links it to her understanding and the shared understanding of the formulation. And she links it to both the dyad of needing to please the vulnerable libidinal dyad, and the one which also gets a bit irritated about the need to please. So she brings in both dyads, and then she also says, and she says it gently, she doesn't force the transfer, she says, maybe that's a way to understand why you get irritated with me. So she's thinking about what's happening with the material, and in a tactful way, she says, maybe that's also something, a way we can understand how you are at times with me. Can you see? So it was, I thought it was a very good demonstration by this is a trainee, but she's done the training now for 3 years, so she's quite advanced. And I thought this was a very good demonstration of how a TFP therapist would work.
That's very beautiful. Yes, absolutely. And very clear. Thank you for that. Going very practically, in terms of setting, what's the frequency of sessions and the estimated duration of a treatment for narcissistic personality or borderline, which typically are considered quite difficult or lengthy therapeutic process? And is there any preferred setting or structure?
Yeah. So again, I think it's a very relevant question. So, TFP is developed by the New York group, who work in both public and private settings as a group. So Otto Kernberg's group work in both public and private. And they very clearly say in the therapy, in the guidelines, it is a minimum of 2 times a week. It can be 3 times a week, but it's a minimum of 2 times a week. Now, I think that that's important because they are saying it's not 5 times a week, because that's psychoanalysis. And I think that the approach is different. But they are saying a minimum of 2 times a week. Now, there's been a very interesting tension between Europe and the United States about this. So we in Europe say, but a lot of our work is in the public sector, and we cannot, if we want to keep psychodynamic psychotherapy alive in the public sector, we need to also be able to offer 1 times a week. So that's a battle that's been won. In other words, within it's been accepted by the International Society that TFP can also be 1 times a week. And I personally feel that that's the correct decision, but I absolutely respect why Kernberg was very reluctant to think about it in that way, because it isn't, and I feel quite deeply it is, if it's practiced correctly, it is an analytic treatment, and it's more demanding to do a psychodynamic psychotherapy 1 times a week. I can see why Otto Kernberg was so so keen that it's 2 times a week. So so that's about the intensity.
Yes,
About the duration, again, I think that the New York group would say, to offer it for less than a year's duration doesn't make sense. We are talking about personality.
of course.
I think in reality that their treatments would go on for longer than a year. Within the NHS, so within my service, we offer TFP for 18 months. And I think that's acknowledging a year is quite short, but acknowledging also that public resources are limited. And again, maybe my view of TFP as being a pragmatic approach, I think it's no bad thing to have an end date so that there's some incentive on the patient's part to work. Because, again, this might be a personal view, but if the unconscious is timeless, our lives aren't timeless. We will die at some point, and there's work to be done if we want to have satisfying lives. So, in some ways, I do respect the thought of an 18-month treatment. And if the patient at some time feels they want to do more work, of course they can then get another episode. But I think there's something about the need for reality and having a clear frame in which the work occurs.
How would the successful treatment after 18 years, nice man, look like for a narcissistic personality presentation? What would you need to see in order to know that this is good?
Gosh, so
That's a,
that's you see, I'm thinking of the patients in my service. So I'm thinking of one patient who, in fact, I saw again, they wanted more therapy, not necessarily from my service, but they wanted more therapy. So I had the opportunity to see him again. And when I saw him again, the changes in his life were, well, there was no change in him feeling, I am now 60 and I have, where am I in my life? I have not achieved. There was absolutely no change in that sense of real desperation in him. And he also was someone that said, and there's no change. It's absolutely, because I worked with him in the groups, I know him very well. He said in this meeting, as he said before, why can't people just listen to me? I'm always right. So he hadn't changed in that way. But what what had happened in the time is that when we saw him, when we treated him, he started a relationship, and I was very pleased to hear that he was still in that relationship. In other words, I think that part of the intervention allowed him to have some sense that he can be very difficult and opinionated, and allowed him to just be a bit less in the relationship. So I thought, that's just wonderful that a very, very narcissistic man is still in a relationship, and he was able to say, I think she's a good person for me. Without her, I think I would really not be managing well. So that was the one aspect.
acknowledges need for dependency, finally.
Yes, absolutely. That aspect, because he just could not, he was so dismissive of her, but there was something in the way he said it, which was an acknowledgement exactly that, I suppose it's the most difficult thing for a narcissist to think that if someone left me, I would feel lost. And he was able to, but the other aspect that there was is that when we, when I assessed him for the first episode of treatment, what he said to me is that my problem is that I dissociate, and that I dissociate for up to, he said I dissociated for 2 years. I have no memory of 2 years of my life. And the approach that TFP would take is to say it's not to get into an argument about diagnosis. But what I said is, well, that's very important that you've told me that. For this therapy to work, you have to have an ongoing memory. So if it happens that you dissociate so much that you forget to come, or that you say you have no memory of previous sessions, then we will mutually agree that the therapy isn't working and we'll discharge you. Can you see that I didn't get into a debate about, yes, there is dissociative identity disorder, or yes, you do have a dissociative disorder. I just went to the frame, in other words, the way that we would work together. So in the course of the treatment, he then didn't have any extended period of dissociation. And when I saw him again this time, he said that he has periods of dissociation which last for a maximum of 3 hours. What I'm saying is there was something about just the direct way of TFP working, which I think helped him with that, what I think was a defense on his part to go into that way of relating, which is, I just can't remember anything. So
Right.
can you see that when I say this, in some ways it's quite limited success, but in some ways it's not that bad, that he still is in a relationship and he dissociates less. And I would regard that as, and he still would meet all the criteria for narcissism, but at least there's some aspects to his life which is a bit better.
It's more contained. Let's assume
Mm.
he proceeded with therapy on his own volition. Let's say he would have probably been able to change further.
Yes.
Yes, absolutely. I'm aware of the time, and you're being so generous today with us. But one last question. For those interested in becoming fully certified in TFP, what does the training path look like?
Yes. So it's attending a foundation course in Transference-Focused Psychotherapy, and the total amount of time for that is 67 hours. So what that usually, how, different courses do it differently, but the ones that I've been most involved in have done it in quite a compressed time. So in other words, we've done it in a set of 3 days, and then another 3 days, which gets in 42 hours, and then a top-up training. After that, one then has a certificate of completion of the foundation course, and only after that can one then do the TFP therapist training, and that requires 2 years of treatment of a patient with regular supervision by a TFP supervisor. So that's really, and then also to say that it would then need an examination to be certified as a TFP therapist.
Okay, wonderful. So, and we will be inviting you for the first 3 days basic training coming up soon for our audience who are interested. You can all look onto the website or reach out directly to our team at training@elephant.com.sg. Dr. Lee, it has been inspirational to speak with you, to say the least. This was very, very rich and insightful conversation. I thank you so much for your time and your dedication to this beautiful work that you do, really. I truly thank you from my heart.
Thank you very much. Very much enjoyed just speaking to you, and thanks for these very interesting questions for me as a clinician. So thank you for the
Thank you.
invitation.
And we look forward to the training. Thank you so much.
Bye bye then.
Bye bye.